So I'd like to tell you about some research opportunities. First one real quick, and then we'll get to Dr. Dauber's presentation. And we just want to remind you, we provide you with, opportunities that we hear about from clinicians and other researchers, genetic counselors, both, medical, clinical, as well as interview-based trials or interventions. And these are just suggestions. We try to make you aware of this research that's going on. But we'll remind you that it's important to talk to your doctor first about the benefits and risks of participating in any type of study. So next slide, please. So this one, I just want to mention, I have sent it out to people through an email blast, but there is a genetic counselor, master's student, Madeline Dyke, with her principal investigator, her mentor at the University of Maryland, and they're looking for any families that have Noonan syndrome couplets. And they define couplet as a parent and a child that have both been diagnosed with the same condition. And so they would like to gain knowledge from this study to help genetic counselors better support and counsel individuals and families with Noonan syndrome. So it's a survey-based phone interview, and they're looking for participants. And so you can see that their contact information there. And if you are interested, we recommend reaching out fairly soon because the study recruitment ends at the beginning of December. And so now I would like to introduce Dr. Dauber. He is currently Chief of Endocrinology at Children's National Hospital in Washington, D.C. He's a pediatric endocrinologist by training, and he works in all areas of pediatric endocrinology, but specializes in studying and treating growth disorders. And so he's going to tell you about a clinical trial that they've initiated to recruit and treat members that have RASopathies as well as other growth disorders. So now I'd like to turn it over to Dr. Dauber. Thanks for joining us today.
No problem. It's my pleasure. And thank you so much for the opportunity to speak with the group. I really appreciate it. Lisa, would you prefer that I just share my screen, or do you want to just advance your slides, whichever is easier?
I can just advance them unless you would prefer.
That's fine. No, that's okay. All right, so why don't we go to the next slide? So our study is looking at a medication called Vosoritide in 5 different genetic categories of short stature, one of those categories being the entire group of children with RASopathies. So I thought I would just give you some brief background. So you may be aware that the way all individuals grow, the way kids grow, is that we have things called the growth plate, which are areas at the end of our bones that are made of cartilage and have cells in them called chondrocytes, which make your bones grow longer. And the chondrocytes have these different zones in the growth plate. And just pictured on the right here is a schematic of the fact that there are many different factors that affect how those chondrocytes grow. If you go to the next slide. And one of those factors that's very important is a factor called CNP, or C-type natriuretic peptide. And back, for now decades, this has been known to be really important for growth. And this is just one experiment showing that when they looked at growth plates from rats, as they add more CNP in the petri dish to the growth plates, the growth plate cultures would grow significantly taller. And when they looked at the exact mechanism, it affected multiple of the different zones in the growth plate, and it stimulates the cartilage that's supposed to say matrix production and increase the number and size of the different types of chondrocytes. So this is a very important factor regulating growth. If you go to the next slide, we found now actually though that there are individuals around the world who have activating mutations either of the gene that codes for CNP itself, or pictured here are of the receptor for that C-type natriuretic peptide gene. It's called the PR2 receptor. And those individuals are very tall. So pictured in the middle here is a patient from the Netherlands who's 7 feet 3 inches tall, and he had actually surgery to help fuse his growth plates because he was still growing. And Otherwise, these individuals were relatively healthy with some, mild skeletal issues as well. But this shows us that if you increase the amount of C-type natriuretic peptide or the signaling through that pathway, it will increase growth in individuals. So if we look at the next slide, now a number of pharmaceutical companies have taken advantage of this knowledge to start to develop new therapies for growth disorders using CNP. So the therapy that's the furthest along is a medication called Vosoritide, which is made by a company named Biomarin. And this is a paper that was published last year in the New England Journal of Medicine, looking at their phase 2 study of Vosoritide in children with achondroplasia. So you may be familiar with achondroplasia. It's the most common form of dwarfism, genetic form of dwarfism. And what this study showed was that the medication was safe, with relatively few side effects. I'll talk a little bit more about that later. And that there was a dose-dependent, somewhat increase in growth in children with achondroplasia when they were treated with C-type natriuretic peptide. So each of these colors represents a different dose cohort. And what's pictured here is the growth velocity. And what you see is from the baseline growth velocity, there was an increase of around 2 centimeters per year, and that seemed to be sustained over multiple years. Okay, if we go to the next slide. So Biomarin followed this up with a phase 3 study, which was just published this year in the Lancet. And what they did, this was a randomized placebo-controlled trial, again, only in children with achondroplasia. And again, they showed that the children who received Vosoritide had an increased growth rate compared to those who received placebo. And pictured on the right is a plot that just shows in all different subgroups, whether it's boys or girls, different ages, different heights. To start out with all of them, it was beneficial in the children who received the Vosoritide. All right, so if we go to the next slide. So I've been speaking with Biomarin for a number of years now, saying that I think this medication, this idea of increasing the CNP signaling would be beneficial not just for children with achondroplasia, but for many other conditions that lead to short stature. And I'll just focus today on the RASopathies. And pictured on the right here is a schematic of the chondrocyte, that cell in the growth plate. And if you'll notice, right in the middle, towards the right there, there's that RAF, MEK, MAP kinase pathway highlighted in gray. And this is that same central pathway that you saw on the RASopathies net slide. So in achondroplasia, the issue is with a mutation, an activating mutation in FGFR3, which is that receptor, the pink receptor in the top left there. And the treatment that is being used is that CNP triangle binding to its receptor in the top right. And those two pathways intersect directly at the RASopathy pathway. And there's very good reason to believe that if this medicine works for kids with achondroplasia, it should help with growth in children with all of the RASopathies, as they all lead to increased signaling through this RAS, RAF, MEK signaling pathway. And if you go to the next slide, this has been shown actually now, other investigators, these are not my studies, other investigators have looked at mouse models of RASopathies. So pictured on the left here is a model of CFC syndrome, right, of cardiofaciocutaneous syndrome. It's a specific mutation in the BRAF gene. And what you see is that the mouse who has the mutation but has received CNP, and right next to that are the growth plates, are able to grow much better and actually achieve a normal length compared to mice that do not have the mutation. And then similarly on the right is a mouse model of neurofibromatosis type 1, where again, administering a type of C-type natriuretic peptide, and this is not Vosoritide, it's not the same medication as we're using today, it's just showing the same principle that if you're increasing C-type natriuretic peptide in these two models of RASopathies, you're able to improve growth. And on the right is showing the actual histology of the growth plate, showing the actual cells, how it can, normalize how they look in the growth plate. So if you go to the next slide. So what we're doing now is a study where we are going to treat children with any of those 5 genetic groups that I showed on the previous slide, one of the groups being RASopathies, with Vosoritide, and see whether those children have improved growth over the course of treatment. And I'll get to the inclusion criteria in a second, but the basic design of the study is that children will come for a screening visit, and for the first 6 months, they won't be on any therapy. And the reason for that is that since we're doing, each child is very different from the others, right? Whether, just as in the RASopathies, every kid is different. There are different mutations, different other medical issues, that we need to just get a baseline growth rate for each child so we know how fast they're growing to start out with without medication. And then all of them will get started on the Sorotide. So there's no placebo control in this study. This is a phase 2 study. Every child who enrolls will receive the medication, but just has this 6-month observation period, and then a period of 1 year where they will be receiving the medication. And the medication is given as an injection. It's a daily injection, subcutaneous, a small shot. It goes right under the skin. It's given with an insulin syringe, so it's a tiny, tiny needle. And it's something you would be taught to administer at home, by our team, and very similar to giving growth hormone at home. And in total, the study then would take 18 months, the 6 months of observation, the 12 months of treatment. And during that time, there would be 4 visits to Children's National at Washington, D.C. We are the only location in the world actually offering this medication outside of achondroplasia. So this is we're the only place giving the medication. And we will cover all of the travel costs. We'll come to that on the next slide. But you would fly in or drive in or train in, whatever is easiest, to Washington, D.C. For those 4 study visits. I can go into let me go over the inclusion criteria, and then I'll tell you a little bit about what happens at those visits. So the inclusion criteria are the kids must be between the age of 3 and their 11th birthday for boys and 10th birthday for girls. And the reason for that is we want all of the kids not to have entered puberty during the course of the study. Not to be pubertal, because that can affect how fast they're growing. The need to have short stature. So if you have, as you know, there's quite a lot of clinical variability in the various conditions in the RASopathies. So if you're growing already at the 25th percentile, we won't be treating you with this medication, at least to start out with. So you must have a height below 2.25 standard deviations, and also have a normal BMI, body mass index, so you can't be underweight for your height. You must have a documented mutation in one of those 5 categories. And we have a whole list of all the RASopathy genes that can be involved, but basically any gene that leads to a RASopathy for which there's a genetic variant the patients are eligible. They can't have growth hormone deficiency. They can't be treated at the same time with growth hormone. So if they've previously been treated with growth hormone, that would be fine. But then for the course of the study, it needs to stop. And in my personal experience, growth hormone can be very beneficial for some patients with certain conditions, but it also does not always work. And there are concerns about using it in other conditions as well. So for patients who have not had a good response, or who, for some reason, the physicians and the family are not interested in pursuing growth hormone therapy, this might be an interesting alternative. You can't have a medical contraindication. So many cardiac conditions are okay, but any conditions for which a drop in blood pressure could lead to a problem, initially we're not going to include. So the specific ones are hypertrophic cardiomyopathy, aortic stenosis, or regurgitation, and that's for safety reasons for this initial trial. And you must live in the United States for the duration of the study. So for regulatory reasons, we're not allowed to give the investigational drug to children who will be residing outside of the United States. So just briefly, as I said, at the screening visit, you basically get some measurements, blood draw, and we do a screening EKG and echocardiogram. And that's that first visit. When you come back for that next visit, it's actually a 2-day visit. where we give the medication for the first time on day 1 and then again on day 2. That first day is a very long day, mostly for just safety monitoring. We give you the medicine and watch through the course of the day to make sure that the child doesn't have any adverse reactions. We also will, at each of the subsequent visits, be putting in an IV and getting drug levels over the first few hours after we give the medicine. We'll be doing some x-rays of the hands and the spine, doing some questionnaires as well, and a bone density scan. And then the visits at 6 months and 12 months are very similar. So the logistics, as I said, it's 4 visits to Washington, D.C. over the course of 18 months. All of the travel costs are covered for the patient and 1 parent. We are hoping, and our full intention is to, and it seems to be helping them. We plan on extending the protocol to allow for them to continue on the medication for multiple years after that. So that is the intention, but that is not set up yet because we're not yet to that point. And of course, study participants, this is obviously completely voluntary, and study participants can decide to withdraw or not participate at any point during the study if they change their mind. And all results from the study will be shared with the participants after the study is completed. And as we move on, we will be happy to share any abstracts or papers that are presented on the way. I was asked to address COVID considerations. So, the situation always may change, but at where we are right now is that travel is permitted at our hospital for medical care. This is considered, while it is definitely a research study, no, I want to make sure that's totally clear. It is considered medical care for which the child may benefit. So it is still allowed to go on. Obviously, we take all of the safety precautions at the hospital. Everyone wears masks and face shields and washes their hands. Everyone gets screened. So everyone gets screened for symptoms, before they come in each day. So those are the current regulations. Depending on how long you're going to be in DC, you may need to get a negative COVID test prior to travel. We're not insisting on that right now, but really it is up to each family to decide their own comfort level with traveling to Washington, to take part of that study. All right, and we currently, the goal of the study, I didn't mention, was to have 35 individual participants. We already have 9 children enrolled in the study. They're all in that 6-month observation phase right now, so we don't have any preliminary results yet. But there is a child with Noonan syndrome in that group of 9. So the benefits, this study is primarily being done to see if it improves growth in children with these conditions. So the potential benefit is that it could make the kids grow better. We are also doing quality of life surveys, specifically looking at the effects of short stature on individuals' quality of life. But I would say that that is a long debate on how important stature is for individuals' quality of life. And I think that's an individualized discussion I'm happy to have with people, and you can have with your physicians as well. So in general, this medication appears to be quite safe. There have been 0 serious safety events in all of the trials for achondroplasia and all of the healthy initial adult volunteers. Now, this medication has not been given to people without achondroplasia, or except for those initial healthy adult volunteers. So there still could be unknown side effects, but in general, as I said, there have been no serious safety events. There are minor, like with any injectable medication, there's some minor reactions at the injection sites, just some local pain, redness, irritation, all of which have self-resolved. This medication can lead to a lower blood pressure. So in almost all of the children who have received it, that has only been picked up by close monitoring of their vital signs. They've not had any symptoms. A few kids, like 3 or so, have gotten temporarily a little bit lightheaded, which has gone away with no intervention as well. And they found basically that as long as the kids have eaten and drank something before they get their shot first thing in the morning, they don't really develop symptoms. But that is something that we monitor for during the study visits. And the theoretical concern, this is a concern that we're monitoring for, is that theoretically, if the kids start to grow too much or too fast, it could lead to excessive bone growth and potentially worsen scoliosis or some body disproportion. That hasn't been seen in the children with achondroplasia, but that's a theoretical concern based on our kind of knowledge of what could happen if you give too much CNP to somebody. All right, and then on the next slide, I won't go through all of these, but just to show that we're doing a lot of different analyses in these studies. So the primary endpoints are looking at, the safety, if there are adverse events, and the effect on height and growth rate. Then we're also looking at body proportions, the effect of bone age x-rays, and then some exploratory endpoints looking at pharmacokinetics, bone density, looking at some biomarkers of the effect, looking at quality of life surveys as well. So that is an overview of the study. I think the next slide just says that I'm happy to answer any questions. I do see one question in the chat. Maybe I'll just address that and then open it up. So this is from a mother of a child with a RAF1 mutation with hypertrophic cardiomyopathy. It's a good question if I think kids with these heart issues will ever be able to use this drug. I really think that it is going to be a kind of an individualized risk-benefit conversation with your clinician, with your doctors, depending on the degree of hypertrophic cardiomyopathy and what we learn more about how much of an effect this medicine has on blood pressure. So, really, like I said, there have not been any significant hypotension events where nobody's lost consciousness. The only one person lost consciousness in the initial trial because they got their blood drawn and the kid passed out, but not related to the medicine. It was just, they saw the needle going in and the kid took a little bit of a nap on the table for a few minutes and was obviously totally fine, like anyone when that occurs. But otherwise, there really haven't been any serious events. So if it continues to, if the data shows that with good hydration, the low blood pressure really isn't an issue, then it may get opened up to children with more significant cardiac issues. But I think that's going to need to be an individualized discussion.
I think the concern might, and correct me if I'm wrong, Jennifer, is that because it's growth oriented that it could cause more hypertrophic cardiomyopathy. But I also understood that this is really targeted at growth plates only.
That's right. So I'm sorry if I misunderstood that then. So the concern with the CNP, there are receptors, a few receptors in blood vessels, not as much in the heart tissue itself. It is in some tissues, but the CNP's major effect is really in the growth plates. So it's not like growth hormone that has a big effect of growth of tissues all throughout the body. CNP's effect is really on the growth plates. So I don't think, so there haven't been in the animal models, in the humans who have extra CNP, there have not been any signs of cardiac hypertrophy. So if that's the concern, I don't think that's going to be a major concern. I think that the concern, the reason those are listed in our exclusion criteria is not because of that concern. It's because those specific cardiac conditions are conditions that if you dropped the blood pressure, it could affect how much blood your heart pumps, which is obviously not safe for you. So that's why those are listed. So the plan for participation, selection, or overflow, 35 kids or more participate. So that I will be ecstatic to get to that situation. We've only been open for a few months and we do have 9 individuals enrolled already. So it's possible that we will get to that. I think it depends on the breakdown of the 35 subjects. So right now, being completely transparent, of the 9 patients, 6 of them have hypochondroplasia, 1 has Noonan syndrome, and 2 have mutations in this gene called PR2, which is the receptor for CNP. So I could see that if we enroll the majority of patients with hypochondroplasia, which is very possible, and we only have maybe 5 or 7 patients with RASopathies, I could see that I will have a discussion with Biomarin and say, listen, we've only got really preliminary data in the RASopathies. I'm going to stop enrolling patients with hypochondroplasia, but I'd like to go up to 50 subjects, enroll more patients with RASopathies. So I think that is well within possibilities, but I just don't know yet. I mean, it really depends on what happens, with enrollment. So comparing the advantages and disadvantages of growth hormone versus CNP and Vosoritide. So great question. I'm going to be completely frank. So I'm a pediatric endocrinologist. I prescribe growth hormone all the time, right? Like all the time. I've used it in tons of children. And I prescribe it all the time in Noonan syndrome as well. So when I see patients with Noonan syndrome, I really often prescribe growth hormone, you know, obviously in discussion with the family. So the advantages of growth hormone are, I would say, twofold. One, it is approved, right? So it's approved for Noonan syndrome. It's not approved for any of the other RASopathies, but it's approved obviously for other indications as well. But it's approved for Noonan syndrome, which means insurance companies will often, most of the time, cover it, depending on your insurance company. But so that's one thing. And so recombinant human growth hormone was first made in 1980 something. I don't remember the exact year, I think around 85. So there are 35 years or so of experience of using recombinant human growth hormone in hundreds of thousands of children around the US. So its safety profile is very well known. And there are risks associated with growth hormone that are known. There are risks of increased intracranial pressure. There are risks of a slipped capital femoral epiphysis. That's a slippage of the hip joint. There's risks of worsening scoliosis. There's risks of increasing insulin resistance. Those are all known and quantified and are rare. In general, it's a very safe medication. And it's known that on average, children with Noonan syndrome, let's focus on, do respond. And, you know, it's not like kids with growth hormone deficiency, but they can grow more with growth hormone. But it's also known that the response is very variable. Growth hormone does not really specifically address the pathophysiology that is found in RASopathies. It's non-specific. It's specific to something else. You know, it's basically like just trying to throw hormone that we know promotes growth at the growth plate, but it's not specific to, that's not the defect that, you know, is happening on a molecular level in the RASopathies. So it's not really targeted, I would say. And the other downside is, at least in some of the RASopathies, and you guys probably know this better than I, more than others, there are at least theoretical risks of increased cancer predispositions. And perhaps, you know, in certain ones. So growth hormone, if you have growth hormone excess, it does increase your risk for certain types of tumors. There's no question about that. So there are theoretical risks, and theoretical is what they are, to using growth hormone in individuals who are predisposed to certain cancers. So there are some other conditions which have very clear predispositions to cancer where I would be exceedingly hesitant to use growth hormone in. Now, the benefits of the Sorotide is that it is, from a molecular level, quite targeted at the pathway, the exact pathway that is affected by RASopathies. The downside of it is that it's never been done, right? So that's why we're doing the study. But I can honestly say to you that I have no idea how this is going to work in patients. Like, I think it should work, right? It works in kids with achondroplasia. It works in mice. I think it should work. I think it should be safe. Like, I take that very, very seriously. You know, this is not something we're doing cavalierly. This was after much discussion with the FDA, in meetings with them, and, you know, review by scientific review boards, and a lot of consideration to make this protocol as safe as possible. But it is not, it's still not known, right? Just to be totally frank, you know, this hasn't been done yet. So it is a research study, and you need to know that. And I think, from my understanding of the biology, it should have less risk. I actually think it should have less risks than growth hormone. But that's what I'm hoping for, and that's what we're hoping to see. Okay, so that's a comparison of that. Do I plan to track other developmental features during the course of the study for other RAS who might have a number of developmental issues? That's a great question. The answer is no. And the reason the answer is no is that we also, similarly, Vosoritide and C-type natriuretic peptide is not known or thought at all to have an effect on developmental outcomes, brain development, or anything like that. So that's really not the focus of this study. Not that it's not important, it's probably much more important in many, many ways, but that's not the focus of this study. Like I said, the only questionnaires we'll be doing is about quality of life issues related to stature. So there's a standardized questionnaire that parents, and if able to, the children answer as well. Have I ever used growth hormone or Vosoritide for a child with Noonan syndrome with a history of juvenile myelomonocytic leukemia? Oh, I answered your question. So the answer is no, I have not. So Vosoritide, definitely not. And I would strongly counsel patients and families to, we are talking about stature. I think you have to be very, very, I personally am quite risk averse. So I'm quite conservative when it comes to using growth hormone. I'm sure there are other people who, if it has resolved, would do this, but I would be very hesitant to recommend that. And you wrote, the next person said, your son is too young right now, but is there a way to stay informed about the study progress as he gets older? Yes. So good question. So I'm always happy to answer questions. So there are two ways that you could stay informed. So one is, the study is listed at clinicaltrials.gov, which is the national registry required by the governments for all clinical trials. So we obviously have complied with that. And if you'll see right there, it says studies recruiting. So if the study stops recruiting, we'll update that in that registry, and it'll say, completed enrollment, or I don't know what it says actually, but it'll say something different. And hopefully, once we have results down the road, we'll be presenting this at meetings to groups, sharing them as widely as we can. But if you ever want to just shoot me an email and say, hey, are you still, Andrew, are you still enrolling patients in the study? I'd be happy to answer that question and see where things go.
And Lee Johnson asked, do you have plans to track other developmental features during the course of the study for other RAS participants who might have a number of developmental issues?
Right. So, as I said, the answer to that is no, we're not really focused on other developmental issues right now.
And I received 2 questions via
Sure.
email from a CFC international family. They
Sure.
asked, why was this test not done internationally? Why are you only doing it in the US?
Oh, the simple answer for that is that I live in the United States, and not to be facetious, but so I'm under the regulation of the FDA. And I'm doing this as an academic, hospital research investigator. I don't work for Biomarin. I don't get any personal money from Biomarin. Biomarin, I should say, is paying, they're giving us the medicine and paying for the study. But I wrote the entire protocol. We have our own independent data safety and monitoring board. I went to the FDA and met with them. Biomarin was not involved in any of those processes. Since I work in the United States, and I'm regulated by the FDA, I'm only able to do studies in the United States. I think that my hope is, if this works, right, if we show good evidence that this is beneficial for children with any of the disorders, and specifically RASopathies, I'm going to be knocking on the door at Biomarin and the other drug companies and say, hey guys, this is a really good therapy for RASopathies. You need to do the phase 3 study, right? You need to do the large international multi-center study in order to get this approved for that condition. And that's my goal, and then obviously they would do it. And, those companies are perfectly capable of doing it. And the achondroplasia study was done all over the world.
And they asked, when will the results be available? When do you think the results will be available?
So it depends on how fast we enroll patients, really. So, starting in a year from February, so February 2022, our first patient will complete the study. And within a few months after that, we'll have results of 9 patients. And then, I don't know, then it just depends on how many more patients, enroll and how fast they do. Other questions I can answer?
I think that's it.
Okay, great.
Thank you.
So no problem. If people are interested on that, here, I'll put
it up. I can put it up.
The last slide has my email and our study coordinator, Tara McCarthy's email. And feel free to shoot us an email and tell us if you're interested, and we'll set up, we're happy to set up one-on-one Zoom calls we've done that so far for every family, to do a one-on-one Zoom call to really go over all of the details of the study and logistics, and make sure you know what you're signing up for.
Thank you so much, Dr. Dauber.